everyone. Today I have Dr. Wesley Ghasem, who is double board certified in internal medicine and interventional cardiology, and did his residency, cardiology fellowship, and interventional cardiology fellowship at Keck School of Medicine. So, how are you doing, Dr. Ghasem?
I'm doing well, Elon. Thank you very much for having me.
Yeah, shall we get into it?
Let's do it.
All right. So the first question I always like to ask is, what inspired you to go into medicine?
Yeah, I love that question because I feel like, everyone in medicine thinks that there is they need to have some perfect story or some epiphanal moment that they decided they were born to do medicine, that they were intrinsically gifted and had to do this special thing. But honestly, for me, I just liked the sciences growing up. I was always good at math and kind of biochem. And so that was kind of just a natural gravitation for me to kind of go into medicine. The specialties, medicine in general seemed cool. You were helping people. And I like the sciences. So it was just kind of a natural progression that I kind of just gravitated to, but there wasn't really any kind of one specific epiphanal moment that I really had.
Yeah, and I think a lot of pre-meds can relate to that. The problem that I know a lot of people have with a story like that, which is a lot of people, is they have a hard time conveying like that in a personal statement when they're
Yeah.
applying. So if you remember, I don't know how long that was ago, but if you remember, how did you kind of convey that to admissions?
Yeah, it's a good point and a good question. And you're right. I mean, I think they want something a little bit more solid than I kind of just like the sciences, and here I am. I think for me, I did give examples of and I think my brother actually kind of had this too, where, our grandmother was very sick in Iran, and she kind of had a lot of health issues. And, there was a doctor there that we really looked up to. And so, you definitely pepper in some kind of personal anecdotes and things that kind of push you in a specific direction, that you want to just, you got to have something that kind of sticks out and is memorable. And so I think for the purposes of an interview or a specific application, you do want to get a little bit more personal, but I figured between you and me, it's the truth kind of prevails here. And, there wasn't really anything in particular that I said, I have to do medicine, and, it's either do or die. And really, I just enjoy it. And I think that should be a fine answer, but unfortunately, oftentimes it might not be.
Yeah, and your brother mentioned, or for those who don't know, his brother is Alex Ghasem, who I interviewed previously. He was talking about how the doctor was doing house calls, and I don't know if this is the same story that you were talking about. How the doctor was doing house calls in Kentucky, and he was just inspired by that kind of story and the service that he was giving. So was that a factor for you too?
Yeah, exactly. I mean, I mean, Alex is a couple years older, so I think he remembers it a little more vividly, and it kind of stuck out to him a little bit more. So I think, he was kind of a little bit more, had a kind of stronger impression towards it than I did at the time. But yeah, exactly. And I think, just one of those things where you grow up and you see doctors held in such high regard and revered for kind of what they do. And it's such a noble field that, I think any kid kind of growing up, it makes sense. It's just kind of a natural progression that you kind of want to go out and help people, but also kind of, feel the reward as well. So.
Yeah. And what specifically inspired you to go into cardiology/interventional cardiology?
So I actually didn't know exactly what I wanted to do going into medical school. When I first started, Alex was doing ortho, so I was like, oh, maybe I'll try ortho and see if I like it or not. And wasn't really for me. I think it was a lot of bones and drilling, and I'm a little bit different than that. So, when I did my cardiology rotation, I just noticed that, these patients are oftentimes the sickest in the hospital, right? They're coming in not only on the brink of death, but essentially die. They've died. They have they're getting resuscitated, and you're going in, opening up their artery, and you're bringing them back to life. And so I think just the one, the adrenaline rush of going in any given day, you could be saving someone's life, and having them 2 days later walk out the hospital. And so I think one, just the mental challenges and the fortitude that you need to kind of make decisions in real time, and then just it's incredibly rewarding, right? You're seeing these patients go from dying to walking out the hospital, and not only are they grateful for their care, but you feel good about yourself too.
Yeah, something I talked about with Alex was initially he thought he was going to do oncologic surgery. And one of the big reasons he stopped was because everyone was so sick and they weren't really getting better. So do you see, is a big part of your practice seeing people getting better, and that's partly why you went into it?
Exactly. I mean, it's kind of a tough balance because these cardiac patients, it's a lifelong disease. Once you have coronary artery disease, once you have blockages in the arteries, once you have a valve that is no longer functioning, we can put a stent in to open it up. We can replace the heart valve, but oftentimes those stents can fail, or that valve can fail over time. These are not permanent solutions for life, and so they'll get you out of your hole, right? If you're dying, they will save your life for sure. But thereafter, it's not only my job, but it's the patient's job to take their medications and diet, exercise, all these things that it's a lifelong process. Once the initial pathology hits.
Yeah, and what kind of pathologies do you see on a day-to-day basis?
So the three major ones are heart failure or kind of valvulopathies, basically as from whatever host of reasons, whether it's from coronary artery disease or blockages in the arteries of the heart, or from if you have arrhythmias and your heart rates are going fast for a very long time. A bunch of different things can cause heart failure, which is basically the heart function has weakened over time. And so the treatment to that is essentially fix the arteries that are causing the blockages that have reduced the heart function, or fix the arrhythmia, which has caused the heart to weaken. So you kind of have to address the underlying cause of whatever's causing the heart to weaken. And so that's one of the big things we do is just heart failure management. There's different medications that you can do, but really it's kind of treating the underlying cause. As an interventionalist, the big thing that I do is interventions for heart attacks. And so when someone has, and a heart attack is basically just an acute blockage of one of the arteries that supply the heart. And so once someone has a heart attack, they come in and we're on a time crunch. They say kind of time is muscle of the heart. And so the faster that we can get in to open up the blockage, open up the artery, the more muscle of the heart is preserved, and the better outcomes. So we basically go in and put stents in to kind of open up those arteries. And then the last thing that I do is something called transcatheter aortic valve replacements. And so when the aortic valve, which is kind of the main, one of the four main heart valves of the heart, that degenerates over time, whether it's from calcific disease or from kind of congenital abnormalities or bicuspid valves that you're born with. The aortic valve doesn't open all the way to allow blood flow through. And so we can actually go minimally invasively through the artery in the leg and put a new heart valve up. And that can last roughly about 10 years. And like I said, it's kind of a chronic process. We might have to go in and put another one after 10 years. But those are kind of the big things that I do as an interventionalist.
Yeah, and how is these minimally invasive procedures changing like the landscape of open heart surgery? Because I know nowadays doing like a coronary artery bypass graft is still done, but it's much less common than it used to be. So how is your specialty kind of changing the landscape of cardiac care?
It's a really good question, and it's a dynamic process. Yeah, I mean, I think if you look at the trends, bypass grafting, or what they call cabbage for short, that the rates have definitely gone down because with the kind of the invention of stents and stenting in general has gone up. So the kind of curves are inverse. There's definitely still a role for bypass surgery, especially if you have significant blockage in what's called the left main coronary artery or your left anterior descending, your kind of proximal left anterior descending artery. Those are kind of the proximal big arteries that supply the major territories of the heart. And if those have significant blockages and they're kind of young, otherwise healthy patients, then they do significantly better with bypass surgery. So there's still definitely a role for it. But if patients are a little bit more high risk, they're a little bit older, the blockages are a little bit more straightforward, then stenting has actually been shown to have equal outcomes. And so if someone can get a stent through a small incision in the artery in their wrist or the artery in their leg, then I think they would much prefer that than kind of having their chest cracked open.
Yeah, and that's a fear that a lot of patients have with just surgery in general, is it's a very, very big process. And a lot of people have lots of fear with surgery in general. So just doing it minimally invasive there, you see, we're going to snake a little wire through your wrist. And it's kind of amazing how we can do that.
Yeah, and it's definitely more palatable for the patient, right? Yeah, they like to hear that it's a small incision in the wrist, and they can oftentimes go home the very same day if it's kind of a straightforward procedure. Whereas, yeah, with kind of bypass surgery, it's kind of a long road to recovery, days to weeks of rehab and all that kind of stuff. So, we're definitely progressing the field, and like I said, there's a role for one or the other, just depending. It's on a case-by-case basis, but the fact that we have this option is huge, especially for patients who otherwise wouldn't be candidates for bypass surgery.
Yeah. What was your kind of journey to becoming a physician, like from undergrad all the way to your second fellowship, I guess?
Yeah, it's honestly similar to kind of what I was describing with just how I always liked sciences and math, and it was actually pretty straightforward for me. I went to Emory for undergrad down in Atlanta, Georgia, and I graduated in 3 years there, and then actually went straight into medical school at University of Cincinnati in Ohio. And so I know there's a lot of kind of non-traditional course or non-traditional applicants where they've taken a year, 2 years off, and that actually whole, quote unquote, non-traditional is kind of antiquated, because I think most people nowadays are taking at least a year or two off. And, I fully support that. I think it's on a case-by-case basis as well. If, you need to take some time and make the right decision for yourself and try some other things, then I think that's completely appropriate. I think for me, I just always kind of knew I wanted to do it, and that's what I wanted to do. And so there's no right answer, and everyone has their own course. And for me, I just wanted to go in. I know it's a long road ahead, so I kind of wanted to get it in as soon as I could. But, I have friends who've had full-on occupations and were in the music industry, and now in their kind of late 40s, decided to go to medical school. So there's no right answer. For me, it was kind of a direct path, but I've seen everyone do everything.
Yeah, I can definitely relate to the try and get there as fast as possible.
Is that what you want to do?
What?
Is that what you want to do? Or are you thinking just
Yeah,
direct path?
that's what I'm trying to. That's the path I've put myself on. But the world does crazy things sometimes, so I'm open to whatever is going to happen to me in the future.
It's tough to predict, for sure.
Yeah. So we talked a lot about what happens when someone is immediately sick or comes basically to your clinic or to the ER and the cath lab. What can some people do to prevent things like that from happening?
So, the biggest risk factors for coronary artery disease are, there are certain things that you can alter and certain things that you can't, right? So age and gender, if you're older and you're a male, you're at increased risk. Nothing you can do about that. I guess nowadays, maybe there is something you can do about that, but that's a different subject. But yeah, age and gender, the older you are, and males, they classically have increased risk for coronary artery disease and blockages in the arteries of the heart. So the things that are a little bit more modifiable are high blood pressure, cholesterol, diabetes, obesity, smoking. And so those are all things that you can really change and take control of as a patient. Making sure that your blood pressure is controlled, making sure that your cholesterol levels are controlled, exercising, diet, things to kind of control obesity. And I know we're kind of in a obesity epidemic and pandemic here, and especially in the US, but really globally. So I think that taking ownership and being able to kind of do what you can to kind of control those things, because once you have a heart attack, it's diet and exercise still remain important, but you're committed to medications, and we're past the point of diet and exercise at that point.
Yeah, and you talked about this previously of like the regimen for a cardiac patient who had a heart attack or just in general is very, very strict. What are kind of the consequences of somebody maybe like skipping a few days or not taking the dosage at the correct time or just things like that?
Yeah, it's incredibly important, especially if you have. So anytime you have a heart attack, you're just in what's called a prothrombotic state, right? You are just more prone to having clot formation and in the subsequent days. The biggest risk factor for heart attacks is a prior heart attack. So if you've had one already, then you are that is the biggest risk factor for having another one. And so if you don't take your blood thinners, if you don't take your cholesterol medication, then you're predisposed to having another heart attack, especially if we put a stent in, because just the technology, any foreign body that's introduced into a body, like a stent, the body wants to attack it. It's predisposed to clot formation. And so if you don't take your blood thinner even one day, there's a risk of that stent clotting off and causing another heart attack. And those heart attacks are actually significantly worse than if you didn't have a stent and you had a heart attack. And so, it is incredibly important.
What happens if somebody does have a heart attack and they already have a stent? Would you place like another stent and kind of like put the stent in the other stent, or like how does that like work, I guess, physically?
Yeah, good question. The question is, why did they have another heart attack in the area of the stent? Was there something wrong were they not taking their blood thinners to cause that stent from clotting? And so in that case, you would just balloon the stent back open and then make sure that they're compliant with their medications and their blood thinners. So that kind of goes back to making sure that you're taking your meds every single day, because if you don't, that stent can clot off. If it is malapose, basically you want your stent all the way up to the artery. Sometimes we place stents that are too small for the artery, and it doesn't kind of expand all the way to kind of get to the artery wall. And so in that case, that stent can clot off. And oftentimes you can put another stent in to kind of help expand the first stent. The most you want is kind of 2 overlapping stents. So you can put an additional stent, but beyond that, a third one, because at the end of the day, you want your stent opposed to the artery wall. And so if you can't get that, if you have kind of multiple layers of stent, you're not getting good contact with the artery, and you're predisposed to kind of getting that clot formation and having another heart attack.
Yeah, and kind of going back to the point of people not taking their medications regularly, how does that conversation go in the clinic to make sure that people fully understand that they really have to stick to this schedule?
I'll tell them, I'll say, you need to take, and the main kind of medications that we give are it's just a baby aspirin along with something called ticagrelor or Brilinta, which are kind of similar blood thinners. And I say you need to take these medications because if you don't, the stent will clot off and you can have another heart attack and die. I will say that point blank, you can die if that doesn't happen. I think some people are a little bit more dramatic about it than others, just to kind of get the patient to really become aware. And, I trained at a kind of a big county hospital where the health literacy wasn't as good. And so you really, really needed to hammer that in and make sure that they were taking those medications. And if they're not going to take the medications, unless they're actively dying and you have to put a stent in, then oftentimes if there's just some moderate blockages or even severe blockages, but we know they're not going to take their medications for compliancy or kind of drug use, whatever reasons, then we won't put the stent in because it's a high risk and they need to take it. And if they don't, the patient can die. It puts them in a worse position if we put a stent in and they don't take their medications.
Yeah. There are some people that advocate for taking baby aspirin, even if they don't have a history of cardiovascular disease, because they think it's like a preventative measure. Is that really true, or is that kind of some social media misinformation?
So that was the classical thinking, is that a baby aspirin can prevent heart attacks and stroke, and it does. It actually does have an impact, but it's a trade-off, right? You're taking a blood thinner, and so you're at increased risk of bleeding. And so does that benefit outweigh the risk? Does that benefit of preventing a heart attack outweigh the risk of having significant bleed? And so you have to take it on a case-by-case basis. If you're a younger, it kind of goes back to those risk factors that we talked about. Age, gender, obesity, hypertension, cholesterol, diabetes, family history. So if all those things are present, then yeah, you probably should be on a baby aspirin because your risk of a heart attack is much higher than the general population. But if you don't have those risk factors, or if they're low, now they're kind of recommending that the risks kind of outweigh the benefits, given the risk of kind of GI bleeding and just kind of overall bleeding with the aspirin. So I think in general, you kind of just have to take it on a case-by-case basis.
Yeah. And I know for me, like working in the ER, people who come in who are anticoagulated are a lot more difficult to treat than just regular or people who aren't, because there's a bunch of risk factors of bleeding and interactions with other medications. So probably for the best.
And if they need a procedure or a surgery, it kind of delays that, or it makes it much more difficult when you're trying to operate and they're bleeding like crazy. And so like I said, there's definitely a role for it, but it's you have to have it has to kind of make sense given the patient's situation.
Yeah. Let's say a patient comes into the clinic with basically newly diagnosed hypertension or coronary artery disease or something. In those early stages, what do you recommend to them that they can basically do tomorrow to make sure that their disease doesn't progress into something that can be very dangerous or fatal?
Yeah. So the big thing is for high blood pressure and coronary artery disease is diet and exercise, right? And so from a diet perspective, I know there's a lot of kind of crazy diets out there, and everyone on Instagram is touting something new every day. But the actual only diet that has been proven to kind of have a benefit is the Pesco-Mediterranean diet. And so that is basically a diet of fish, lean chicken, fruits, vegetables, nuts, legumes, grains, that kind of stuff. So avoiding fried food, processed food, red meats. Those are kind of the big things that that have actually been proven to be effective. And whether or not, I know red meat kind of gets in eggs, and there's always back and forth on that, but we don't, that data isn't out there, whether red meat it is or isn't beneficial. But what is clear is that Pesco-Mediterranean diet does have an impact. And so that's pretty much what we like to recommend, especially because there's data actually to support it. The other thing is just exercise. Obviously, exercise is incredibly important, and that's something that the patient can control. And so it can actually lower your blood pressure by about 10 points. It's not going to get you, if you're running in the 160s systolics from a blood pressure perspective, it's not going to get you all the way down to normal. And so oftentimes I'll say, yeah, you definitely should and can do exercise. But, oftentimes, and a medication probably is warranted as well. So, but if you're running in the 140s, even up to 150s, I've seen exercise and diet kind of turn blood pressure around on its own. So, I think doctors sometimes get a bad rap with being kind of tied at the hip with the pharmaceutical industry and dependent on them. But, I've got no skin in the game from that. Like, and most doctors don't. So, if diet and exercise is always, if you can be without medications and maintain a healthy kind of blood pressure and cholesterol, then I'm all for it.
Yeah, I was about to ask, like, what is the balance between prescribing like a antihypertensive versus just doing lifestyle interventions? Does it depend on like the patient or just the numbers that you see on the blood pressure cuff? Like, what is this? What is the weighing that has to go on?
Yeah, I always try to, especially if it's just high blood pressure or cholesterol, I always will opt for diet and exercise first. We'll say, I'll give them an exercise regimen, or refer them to a rehab facility, or, I'll give them, I'll kind of give them the nuts and bolts of the pesco Mediterranean diet, and I'll say, give this a shot for 1 to 2 months. We'll come back, we'll repeat your cholesterol, we'll repeat your blood pressure, and we'll see how much of an impact it's actually had. And if it has, if it's trending in the right direction, or if it's made significant improvement, then, we'll give it another shot and we'll continue it. If it hasn't really changed, or sometimes it gets worse, then, then I kind of bite the bullet and say, you need to kind of be on a medication to kind of lower it, because what you've been doing hasn't been working. And so, but yeah, I'll always try diet and exercise first, unless, like I said, they've already had a heart attack or they've already had something, then, the horse is out of the barn, and, we're way past the point of diet and exercise.
Yeah. Speaking of, I guess, heart attacks, let's say someone basically like at home, they're having the classic like elephant sitting on my chest, or those kind of symptoms. What's the process of them coming to the ER versus like seeing you? How does that go?
Yeah, so if you ever have those symptoms of elephant sitting on my chest, and oftentimes, yeah, you'll get the chest pain, you'll get nausea, vomiting, sweating, do not call my outpatient office. Call 911, call EMS immediately, and go to the ER. That, like I said, time is muscle in those cases. So if you truly are, even if it's not a heart attack, you need to be ruled out for a heart attack. And so you don't want to take that chance and take that gamble. So just call 911, call EMS, have them evaluate you and bring you to the ER. And if we find that you actually are having a heart attack, then you'll be glad that you did call, because like I said, time is muscle, and the faster that we can go in and open up that artery, the more of the heart muscle is going to be preserved, and lives will be saved. And so that would be my recommendation, is to not call my office if that happens.
Yeah. So basically, or what I was trying to say is they come into the ER and they're like, they have diagnosed heart attack.
Yeah.
How does that process come in with you taking them to the cath lab and
Gotcha.
all of these things?
So yeah, EMS will kind of pick them up. They'll go into the ambulance to the emergency room, and then oftentimes, en route, they'll do an EKG. The EMS will do an EKG and will show STEMI. It'll show a heart attack. And then at that point, they'll reach out to the ER docs. They'll take a look at the EKG. And then the ER docs, if they think it's like a slam dunk, then they'll call me and say, hey, can you look at this EKG? And then I'll either confirm, or I'll say, it looks a little borderline. Repeat an EKG once they get to the emergency room. And so if it's pretty slam dunk, then while the ambulance is coming in with the patient, I'm driving in within speed limits, and I'm arriving, and I'm meeting the patient in the ER. So that's time that they're not having to wait in the ER for me to come. I'm already coming in while the patient is coming in as well. And so that saves us time. And then The ER staff and then my cath lab staff will kind of talk and coordinate. They'll pick up the patient. We'll load them with a bunch of blood thinners to kind of break up that clot with medication on the way to the ER, or on the way to the cath lab, where they'll get prepped and draped, and we'll do the procedure to kind of open up their arteries there. So it's a very quick process, and the times that we want is what's called a door to balloon time, or a first medical contact, actually. So when the EMS actually sees the patient in the field to when the first balloon in the artery is opening up the artery, of 90 minutes. So it's pretty quick, but that's what's been shown to kind of have the best outcomes.
Yeah, and that's similar for strokes, if I remember correctly. How much call do you have to take? And if it's like a lot, how much burden does that have on your life as a whole?
I'm going to switch over here. I'm getting a little glare.
Yeah. Please stand by. There you go.
All right. Is that better?
Yeah.
All right. Call. So that's what's kind of not ideal about being an interventionalist, right? Is that, you're dealing with emergencies. And so you do have to come in the middle of the night to, people have heart attacks at all times of the day. So for me, I'm kind of in a cardiology group in a private practice in LA. And so there's 5 interventionalists in my group. And so we'll just do what's called Q5 call. So one person every 5 days is on call, and we just kind of rotate days. So it comes out to about 1 weekday a week and then 1 weekend a month of call. So it's definitely doable and manageable. You can still have a relatively normal lifestyle. But it's really not that bad. It's 1 weekend a month, which isn't terrible, and then 1 weeknight a week, in my case. And that seems to be about the average for an interventionalist as far as call.
Is it much more when you're a fellow or fellow?
Yeah, as an interventional fellow, I was on Q2 call. So every other night I was on call. I was either on call or I'm coming off of call, and that cycle just repeated. So I was working every other weekend, and then every other night was on call. And you don't really get what's called a post-call day, right? Like if you're oftentimes in residency, if you kind of worked the night, then they'll give you that post-call day off to kind of rest and sleep. But yeah, in our case, we kind of just kept going. If if there's a case that lasted throughout the night and you had to put them on ECMO, or you had to kind of do something emergent, then you wake back up at 6 a.m. and you start the day over again. There's no days off.
Sounds very, very rough.
Yeah, I mean, fellowship was definitely, it's a training process, and it was good from the perspective that you get as much learning and hands-on skills, so that when you're actually practicing on your own, you're ready for whatever hits. And I think USC was very good at from that perspective. Just great mentors, great training program, and overall a really great place to train.
Yeah, the ER doctor that I work with also did his went to medical school at USC, and he was like, that was the best time of my entire the whole process. Like I really like being over there.
It's like, it's like you build camaraderie, right? Like everyone's going through it all at once at the same time, and so it brings you together with your co-residents, your co-fellows, and they always say kind of the hardest times are the times that you look back on the most fondly. And so I can definitely speak to that as well from a training perspective at USC. And it was great. It was now that I'm done with it, it was great.
And because you were at USC for a long time, for medical school, for residency, and for both your fellowships, do you think that being in one place for a long time afforded you opportunities that you wouldn't have gotten if you had moved across the country?
It's a good question. I think, one of my mentors used to always say it's kind of a red flag if you stay in the same place for your whole training, right? Because you don't get to experience how other programs practice, or how other programs, or how different specialists do different things. And so there are great things about what USC is doing that, you know, the Mayo Clinic doesn't know about, and vice versa, right? And so I think if you kind of do train at different programs, you kind of find out different things that you otherwise wouldn't have. So I would probably tend to favor training at other places. But for me at USC, it was just a, you know, I was getting good training with good faculty that I've built relationships with. And so that is the one benefit, is that, you know, the more comfortable they feel with you and the more they trust you, the more they let you do and the more they teach you. And so it's a trade-off versus, you know, trying and experiencing new things where you're kind of just meeting those faculty and you don't really know, and they don't know you and they don't know how much to teach, versus kind of developing those relationships over a while, but staying in the same place. So it's again, no right answer, but I'm pretty happy with my decision to kind of stay at USC for a long time.
Yeah, and I think those relationships, as you move forward in your medical career, can be super valuable, especially if you want to do like research or some more academic stuff. Then knowing the faculty, or like they've known you for a long time, can really push you forward in like climbing the ladder, I guess.
For sure. Yeah. I mean, I'll always have those relationships. I'll always have those mentors. And, you know, if I ever want to go back to USC, or if I have any questions, or, you know, they're always there for you. And so it's definitely a lifelong friendship and relationship that you kind of build with your mentors and the people that train you, it makes a difference if you stay longer and kind of strengthen those relationships over time.
Yeah. So working in private practice, do you like a surgeon would, like kind of split up your day between doing procedures and doing clinic, or is it like one clinic day, one procedure day? How do you balance between those two things?
Yeah, I've got about 3 to 4 half days in the office. So in the clinic, seeing patients, and then the other kind of 3 to 4 half days out of the week is being in the lab, doing procedures, and then seeing consults in the hospital as well. So it's about a 50-50 split. And it's good. So like in the mornings, I'll do whatever cases I have scheduled, and I'll see patients in the hospital. And then in the afternoon, I'll go to the office and see my clinic patients. And if a heart attack comes in at some point during the day, then you kind of break off and go kind of operate and fix the heart attack, and then kind of go back to your routine schedule.
Yeah. And would it be kind of fair to say that the clinic is more, you're seeing like the chronic cardiac diseases, and the cath lab is very acute things that you need to fix right away?
Exactly. Yeah. I mean, so we still put in stents for non-heart attacks, right? Like if someone is just having what's called stable angina, where they get chest pain when they walk, but then the chest pain goes away when they rest. Oftentimes we'll take them we'll do a stress test on them, and that happens to be positive. And then kind of on a non-urgent basis, we can go in and take a look at the arteries of their heart and see what kind of blockage they have. And those are kind of stable plaques that we're evaluating, not necessarily as a heart attack or an emergency, but just to see where the blockages are and how significant they are. So we'll have some scheduled procedures where we're just looking at the arteries of the heart to see if there are significant blockages that are worth opening up or not.
Yeah. So in my research, trying to find good questions to ask you, I saw you did some research with the NFL. So kind of on the other side of the spectrum of what can the average person do to improve their heart health, what can an athlete do to improve their heart health?
Yeah, it's a good question. And, you know, I think we like to kind of hold athletes in kind of higher esteem and, you know, almost as superhumans, but you really have to treat them just like any other patient would. You know, they have just the same risk of high blood pressure. They have NFL players have about 5 times the risk of AFib. And so there are definitely certain things that you need to continue to screen them for, and not just take for granted that they're an athlete, they're probably healthy. And so all the appropriate screening that you would otherwise do, you need to do with athletes as well. But, you know, they're, especially with the blood pressure perspective, I would say, like, they, you know, we always say diet and exercise from the initial management of cholesterol and high blood pressure. But in these athletes, they're already exercising to the max that, you know, someone otherwise would. And their diets are very, very regimented, and very strict. And so if they have high blood pressure, then that's despite great diet and exercise that they're already on. And so I think a lot of physicians are hesitant to start blood pressure medications and trial diet and exercise, but they're already maxed on that. And so I think a good message is to really just have a low threshold. If they are truly persistently having high blood pressure, to just start them on a medication, because they're already maxed on the lifestyle modifications.
Yeah.
The other thing is something called a CPET. It's a cardiopulmonary exercise test. That's something that we can kind of do to look at their MVO2 max. And we kind of use that as our baseline to see basically how strong is the heart working and how much oxygen consumption is it requiring. And you can kind of tailor their exercise regimens based off of what their MVO2 max is. And you can actually kind of trend that and chart that to see, you know, from their baseline, does this exercise regimen improve their MVO2 max? And it's kind of an objective measurement of their kind of myocardial oxygen demand.
Yeah. And going back to the point of AFib, which is super interesting. I did not know that the athletes are at a higher risk of AFib.
NFL in particular.
Yeah. If somebody who either like has AFib already and is wanting to get into more like fitness, or someone who is an athlete and develops AFib, how does their exercise regimen change, if at all?
Yeah, it usually doesn't. You know, the question is, what did the AFib come from? And you know, oftentimes it is from some form of stress. Any form of stress really can kind of cause AFib, whether it's physiological stress, oxidative stress, emotional stress. Those can all kind of cause arrhythmias. And so the key is really to address whatever the underlying cause is. And oftentimes it's really not an exercise thing. The exercise is kind of just the bystander from something else going on. And so, you know, when someone goes into AFib, you want to make sure that they have a structurally normal heart. When, you know, your heart has kind of an electrical conduction system where if the heart is enlarged or stretched, then the conduction system is stretched, and that can cause AFib. Or if their thyroid levels are out of whack, then you need to put them on thyroid medication to kind of make sure the thyroid levels are good, and that can cause AFib. And so you definitely want, there's a checklist of things that we check for to see what exactly is the cause of this AFib. Sleep apnea can cause AFib. And so there's a lot of things that we need to kind of rule out and address the underlying cause, which is kind of the underlying theme of cardiology in general, is figuring out what exactly, you know, is the source versus, you know, the response.
Yeah, I got kind of an interesting question. Would you say
Sure.
the heart is a sensitive organ, or it can kind of take a beating?
Good question. I would say it depends on the person, but you know, I think it depends on the person, and I think it depends on your age. I think if you're young and otherwise healthy, the heart can withstand a lot. You know, you can go on heart lung bypass surgery, or a bypass, what's called ECMO, and the heart can respond beautifully if you're young and otherwise healthy. The older you get and the more kind of chronic illnesses you get, the heart becomes more sensitive. And so as you age, and the heart, it just kind of wears out like any other organ would. So I would say it depends on age and risk factors. If you're a young, healthy person, the heart is very, very resilient, and you can literally die and get resuscitated back, and the heart can respond very, very well if you're young and take care of yourself.
Yeah. Does that, if let's say if you're young and you're like, let's say like a track athlete, and you kind of continue that as you grow older, do you see some of the what's the word? Some of those, like the resilience carrying over when somebody's getting 60 or 70 or even older?
For sure. Yeah. I mean, the more you take care of your body, the more you take care of yourself, then the heart responds appropriately as well. So if you live a certain lifestyle where you're eating well and you're exercising consistently, then you're going to do much better than someone of an equal age who hasn't taken care of themselves as much.
Yeah. So kind of starts, I guess it starts from childhood. You got to
It
make
starts,
sure.
yeah, exactly. And it's, it's in your hands as the patient. You have a lot more say than you think you do.
Oh yeah. That's a big thing, like agency in your own health. When people just, how do I phrase this? Because you have so much agency over your health, like just even now with all this information out there, there's a lot of things you can do right now to act on how you feel or what you want to do in the future or how you want to function. It's all yeah. And obviously, like, the physician has a very important role to play in allowing the patient to use that autonomy. But it's very, very fascinating stuff.
Yeah, it's a shared decision-making process. Everything is a discussion. I think kind of back in the day, the doctor would tell you do this, 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 you need to be on this medication, this, and there was no kind of dialogue. I think now with, access to resources and you know, at your fingertip, right? You can go on the internet and look up anything, any study. It sort of empowers the patient to kind of make their own decisions and have a dialogue with their physician about, what their goals are and kind of make a mutual decision that benefits everyone.
Yeah. Going back to the point of athletes and doing research with the NFL, how does someone do that? Get collaborate with athletes or athletic agencies or something like that?
Yeah, it's I was very fortunate in that I had a mentor at USC who worked with the NFL, had done several studies prior with the NFL, and so you know she basically kind of was the front runner and kind of organizing this, and we basically just kind of did a literature review of patients in the NFL and kind of what these new digital biosensors are doing that can kind of track your heart rate and blood pressure and MVO2 max and you know sweat receptors and looking at your potassium levels and everything in real time and looking at kind of muscle strain. And so there's a ton of things that technology has done to kind of advance the field, and it has significant implications, as far as sports betting and, who's going to sit, who's not going to sit. And so you can really kind of modify these in real time. And, a lot of NFL teams are kind of using these digital biosensors to rest players before they know, before injuries occur, when they look at kind of overall sheer stress on the body. And so, if used appropriately, they can really have a significant impact on player health, which obviously, as we know in the NFL, is really difficult to manage and is kind of a prime focus right now.
Yeah. Do you think there's ever a point where you're monitoring too much and it becomes harmful rather than beneficial?
Yeah, I mean, it's a good question. I think if it's invasive, then yes. I think if you're doing things where there's potential for risk, then maybe it's not a good idea, because that can kind of lead to downstream testing and unnecessary procedures. But if if it's a non-invasive method and you're just checking kind of electrolytes and stress levels, and I think in that case, that has more potential for good It can be used for alternative uses, like I said, sports gambling and some kind of recreational stuff. But I think for the most part, if the intent is to prevent injury and look at things in real time, then I think those kind of benefits outweigh the risks.
Yeah. And what about for the average person who's just kind of worried about how they age or their heart health? How much, I guess, how much tracking is too much?
Yeah, I think a lot of people are kind of taking it a little bit too far. There are people who are, which is perfectly fine, honestly. Like if they want to, they're like we said, you're empowering yourself to kind of look at your health, and I'd rather have it that way than someone who doesn't care at all. So, you know, some people are looking at like heart rate variability and, sleep and which is all good. I don't know, and there's not real good data to say whether or not that actually has any benefit. And so I think if you're obsessing over it, then and if it's affecting your kind of mental health and wellness, then that's kind of the point where you need to take a step back and say, how much has this actually benefited my cardiovascular health? Tracking this 24/7, am I doing anything differently? And if the answer is no, then maybe pull back. But if you feel like it has helped, and maybe you're looking at some objective measures where it has helped, then by all means, if it's helping, then go for it.
Yeah, kind of in a similar vein. When I was like 13 years old, I learned that if like athletes who are elite, their heart rate is really, really low. Like the thing that my science teacher says, like 30 or 40 beats per minute. So, and now knowing more about medicine, that sounds crazy bad to me. So, first of all, is that a bad thing? And should someone who's wanting to do more intense cardiovascular activity, should they look to see if their heart rate is basically dropping, like their resting heart rate?
Yeah, I mean, it is. So your teacher was right. Basically, yeah. I mean, kind of elite athletes, you'll see this, especially kind of long distance runners or swimmers, Olympians. They'll have very, very low resting heart rates, 30s, 40s, and that's physiologic. That is basically the heart doesn't really need to work that hard to get blood to the rest of the body. And so if you have a resting heart rate in the 90s, 100s, that's basically saying that just at rest, your heart needs to beat 100 times a minute to really get blood flow to the rest of the body. So having a low resting heart rate is good if that is physiologic, if you have worked to get there. But where it becomes not good or unsafe is when it is what we call a pathologic problem, right? So there's physiologic, which is good. Pathologic is the heart should be going faster, but cannot. And so in that case, whether it's a conduction system problem or there's an underlying disease, those are kind of when we start to think about putting pacemakers in to kind of help the heart rate get up to a normal level. So the two things we look for is one, are you an athlete? Are you having symptoms at that low resting heart rate? Are you getting dizzy, lightheaded, passing out? And if the answer is yes, then yeah, you probably do need a pacemaker. But if you're not having symptoms and your heart rate's that low, and the other thing is your heart rate responding appropriately? If you go and exercise, if you go and walk, does your heart rate go up with exercise? And does it have the ability to kind of get to rates where you need it to kind of perform specific tasks? And so usually with a physiological response or an athlete, their heart rates will get up to the 200s when they're going, doing their events, but then they'll go back to the 30s and 40s when they're resting. Whereas, for kind of oftentimes elderly patients or patients who have pathologic problems, their heart rates are in the 30s, 40s, and they stay there. Even when they exercise, it can't get up. It can't mount that response. And that's kind of when we need to kind of talk about pacemakers.
Yeah. Is that the only factor that you consider when looking at pacemakers, or even like looking before that. Some of the factors that you consider for even like a stent or a different intervention like that?
So yeah, there was multiple indications for pacemakers. It's a wide list, so we don't have to kind of go into every single one, but the main one, and obviously the most common one, is what they call symptomatic bradycardia. So if your heart rate is low and you're having symptoms from it, that's when we need to talk about kind of a pacemaker. Another one is if you're passing out or you're going into what's called heart block, where your conduction system is just the top of your heart, the top chambers of your heart and the bottom chambers of your heart cannot communicate because of an electrical conduction abnormality. That's oftentimes when you need a pacemaker as well. So there's a bunch of different indications, but those are kind of the main ones.
Yeah. Mentioning heart block just gave me an interesting idea. What are some of the tips that you would give to med students on how to remember EKG rhythms and just read EKGs in general?
I'm a little bit removed from that as far as the basics are concerned. It's one of those things where, like, I feel like as you're going through it, you can kind of provide better advice because you're kind of, where the hiccups are. Now it literally is just like innate to me. I'll look at an EKG and I can tell you right away, like, you always want to make sure that you are in a normal rhythm and a normal rate. And so those are obviously the two most important things that you look for. Is there a P wave before every QRS? Marching out your QRS is to see, how fast is the patient's heart rate going. So if you can kind of differentiate whether you're in a normal rhythm versus an arrhythmia, and then how fast the rate is going, those are kind of the two big things that will get you about 90% of the way there.
Okay, that's pretty encouraging, I would say. Those are, at least for me, I can do that. I can differentiate that.
Yeah.
You get into,
well, you're a natural.
Yeah, when you get into some of the weird, I guess like more obscure rhythms, like, I don't know, torsade de point or whatever, then you lose me.
Some of those are tricky, and that's why my training took 7 years. So you don't expect to know every EKG finding, and there are specialists there for a reason that can help you out. So
yeah. What was your training like, both your internal medicine residency and your cardiology fellowship and interventional cardiology fellowship?
Yeah, so residency was it was a little bit easier than cardiology fellowship and interventional training. It was, it's 3 years of training, and you kind of just rotate through the different subspecialties, right? So you're going through GI, you're going through cardiology, you're going through endocrine and rheumatology and hematology, oncology. So you're basically seeing every single kind of subspecialty, and you're going to the ICU and you're going to the CCU. So you're seeing you're basically getting a broad width of every single kind of subspecialty. Oftentimes, you're kind of the quarterback, right? As an internist or a hospitalist, you're the primary doctor, and then you're consulting different subspecialties, and you're kind of making sure the patient kind of gets their overall care, and the subspecialists are kind of doing what they're supposed to do. And so I kind of knew that I wanted to do cardiology right off the get-go, and interventional as well. And so, medicine for me was okay because I was kind of rotating through subspecialties that I didn't really want to do. And so, but it was kind of just something that you kind of have to get through. And the best cardiologist, the best interventionalist is has a good foundation in hospital medicine. And so if you're a good hospitalist, you're going to be a good cardiologist. So you definitely need the foundation, and it's important. But sometimes you're kind of, in rheumatology clinic and feeling joints, and you don't want to be there. So.
Oh boy, I know. I'm sure a lot of people can relate to that.
Yeah. There's anything wrong with that.
Yeah. Or they want to do rheumatology and they're in the CCU and they're like,
exactly. And you're 100%. So different strokes for different folks.
Yeah. And kind of going back now to what you see currently, How have like these GLP-1 agonists kind of affected your practice and the things that you see?
It's a good question. GLPs, it's making a big impact, honestly. Like diet and exercise, like we kind of talked about, can only go so far. And once you've kind of reached that limit, then you need to start looking at medications. And so there have previously been some medications that have had some benefit, but there have also been some significant side effects that made the medication intolerable. And so with these GLP-1s, the they've been proven to be effective with pretty limited side effects. I think kind of the way it works is it slows gastric emptying, right? And so it promotes insulin and decreases sugar in your body, and so you feel full quicker and essentially all the time. And so some people can't really tolerate that because it's kind of that feeling of being bloated and full that they kind of feel throughout the whole process, and they can't tolerate it. But for the most part, I think people are tolerating it pretty well, and the outcomes are great. I mean, people are losing kind of 10 to 40 pounds, and it's really minimizing the need to go for gastric sleeve or gastric bypass surgeries. So avoiding kind of doing these invasive procedures with just the help of a medication.
Yeah. Is that something that you prescribe, I guess, instead of antihypertensives or cholesterol medication, or in addition to?
It's more in addition to. It's a supplement, and it's I'm not kind of an endocrinologist or a diabetes doctor, but these medications are improving glucose, and so they're often given for diabetics in conjunction with metformin and statins, but they serve different roles. I think these are in particular are for improving glucose and then lowering BMI or improving obesity. And so they're not standalone medications, and they shouldn't be. They're more for kind of weight loss and targeting kind of the obesity risk factor for coronary disease, separate from high blood pressure or cholesterol, which are treated with different medications.
Yeah, and I'm sure in your practice, like you see a very high percentage of people who are obese and really have tried and struggled to lose weight, and now like finally there's an easy way to do it. So it's really going to be huge impact in healthcare.
Yeah, no, I mean, I agree. I think, you'll see like Joe Rogan and people talking about, I will not take any medications. And if it's for kind of a primary prevention perspective, and in his case, he's probably right? Like he has the discipline, he has the resources, and his diet and exercise is probably very optimized to the point where he doesn't need it. But oftentimes with our patients, and especially from a health literacy perspective or an access to resources and good nutrition, it's tough for them to. And, maybe oftentimes, our body has its own set point as far as weight is concerned. And it is very hard to change that set point. And so it's hard for patients. And so, if diet and exercise, they just can't do it. And obviously that's obviously our first recommendation. Then, fortunately we have these GLPs that are a very good supplement to diet and exercise without having to kind of go so far as to do gastric bypass or invasive surgeries.
Yeah, there's a subset of people who say taking Ozempic is cheating. What do you think of that mentality that it's cheating to take?
I think it is. I wouldn't call it cheating. I think it serves a very specific role. I think if you are doing it to replace or substitute diet and exercise, then it's not the right strategy. And so maybe that's what they say when they're saying cheating, is that you can't just use this as a crutch, because you're becoming dependent on this medication. I think you need to use it in conjunction with diet and exercise as opposed to a substitute for diet and exercise. So, not necessarily cheating, but, something that you should use in conjunction with, as opposed to just using it to avoid doing things that you should be doing.
Yeah. And if someone is like sticking to their regimen, they're doing the diet and exercise, they're taking Ozempic, all their medications, have you ever seen someone kind of get off of them? Or is it a thing that once you're diagnosed, you're on it for life?
No, yeah, I mean, you can definitely come off of it. It just depends what your weight loss goals are. Oftentimes, patients who do come off of it will gain the weight back. So it's one of those things where, you don't have to come off of it, or you can come off of it if you want to, but oftentimes that weight kind of comes back. So you kind of are dependent on it from a certain perspective. But like we kind of talked about with diet and exercise, if you keep to a strict routine and you're consistent with it, then oftentimes, there's no reason why you have to be dependent on, on these medications. There's diet and exercise can go a long way.
Yeah. What do you personally do for as cardiovascular fitness or just fitness in general? I'm pretty curious.
It's a good question. I like to, I think the best data is on both kind of resistance weight training and cardio. And so I usually will do that. Usually when I go to the gym, I'll run a mile on the treadmill, and then depending on the day and how much time I have, I'll kind of do some kind of resistance training, and free weights are mostly what I do. So chest, curls, bicep, all the kind of I probably should do a little bit more lower body than I do, but isn't that all of us?
Yeah, that's the classic gym bro problem.
Yeah, exactly. It's I'm all about the glamour muscles, the bis and the tris.
There you go. And you're limited on time. You only have to high yield muscles.
Exactly. Yeah. If I had more time, then yeah, I like to say I would do some lower body stuff, but who knows?
Yeah. So what kind of medical student do you think is really attracted to cardiology and interventional cardiology?
I think the type of med student who likes the combination of critical thinking, who loves the pathophysiology of the heart and how it functions, but also likes hands-on stuff and doing procedures. And I think from an interventionalist perspective, it's really the perfect combination of both kind of operating and using your hands and using your mind and really critical decision making and very, very sick patients and complex patients. So it's someone who likes both of those things and wants a nice balance. I think will like being an interventionalist. The lifestyle, if you want to work kind of 8 to 5, not really for you. Because we do have call, we do have emergencies. So those are things you kind of have to weigh in on, whether it's worth it from a lifestyle perspective to do those things.
Yeah. A criticism that I've heard probably once or twice about surgery is that it's all hands and no brain, which I very much disagree with. But like for someone who says that, seeing like the cardiology or interventional side is kind of the mix of both that they would probably want.
Yeah, exactly. I mean, I agree with you in disagreeing with that sentiment as well. Like my brother, he's an orthopedic spine surgeon. Ortho kind of sometimes has that rap of just being surgeons, but that's one of the most competitive specialties in medicine, and so you have to be very, very smart to go into it. Yeah, I mean, you lose some of that medical knowledge that you gain in medical school, the farther out you get, because you're doing a very niche specialty. So, but that's why there are different specialties out there that can do what they're supposed to do, and it's a team effort. And so everyone who gets into medical school is very, very smart. and you're just pursuing what you want to learn, and you forget some of the other things that you're not practicing on a day-to-day basis, and there's nothing wrong with that.
Yeah. So some of my last questions for you are,
Yeah.
what are some of the new emerging technologies that you're seeing in interventional cardiology?
It's a good question. It's kind of, we're far from it right now. You know, with kind of robotics and doing procedures, there are, you know, once you kind of what we call engaging the guide catheter and getting your wire down the artery, there are certain robotic tools that you can kind of load your balloons and stents on, to that will kind of auto function and actually deploy balloons, deploy stents for you. And the benefit to that is obviously kind of in interventional cardiology, the more you're in the room, the more you're using fluoroscopy and cine, which are radiation. So if you can have a robot in there, where you're kind of out of the room, out of you know, shot distance from radiation, and operate the robotic from outside the room, then that limits your exposure, and can have some potential benefits too. But it's kind of still in the early phases, and we're probably 5-10 years away from anything meaningful for that. Either way, I think kind of robotics and AI in medicine is, should be used as a supplement to medicine. It by no means will replace it. You know, you need critical thinking skills. You need kind of patient surgeon experience, and so you know, it can definitely be used as a tool, and it has its purposes. You know, there's a robotic incision is going to beat a human's incision every time, right? It takes away that, you know, it's very objective, but can it adapt? Can it respond in real time to certain things? And I think we're way, way away from that.
Yeah. And the most common argument I see for why AI and like robotics will be a supplement and not necessarily a replacement is, like, as humans, we want to talk to another human, like, about what the problem is going to be or what's like going to happen, and we kind of know how to present it to another human, and we can kind of like we just know how to be with humans, I guess, is the right thing to say.
Yeah, you feel comfortable talking to a human, and that's a perfectly natural response. And I think you divulge more and you're more honest, and you kind of know how to speak, and so that helps the physician when you're getting a full history. You know, the history is probably one of the most important things that we do as physicians. And actually, it's kind of another thing that AI is doing. There's an app. There's a couple of these apps now that you just press the record button while you're getting a history from a patient, and they will AI will basically summarize and do your HPI for you. And so
Taking my
actually, yeah, exactly, exactly. And they actually, some of my colleagues that are using it actually say it's pretty good. So maybe in certain degrees, you know, it can be helpful, but the patient is still talking to you. It's just being recorded.
Yeah. Literally taking my job. That's all that's all I can say for that one. So if you had to go through your journey again, would you change anything? And if you would, what would you change?
Nah, I wouldn't change anything. I mean, it's there, whatever good or bad has happened, and it shaped who you are, and, you know, the physician that you are today. And so, you know, there's definitely challenges and difficulties, and no system is perfect from a residency or a training perspective. You know, they always kind of talk about how residents and fellows are underpaid, and yeah, like maybe they probably are underpaid. But at the same time, you know, you get really good training, and it's an investment, and you know, you make decent money now as, you know, outside of residency. And so it is what it is, and, you know, no system is perfect. Everything, there's flaws in everything, but it just kind of shapes your experience. And I have no qualms with kind of what I've gone through to kind of be where I am today, and I wouldn't change it for the world.
Yeah. And my last question is,
Sure.
what would you say to the medical student who aspires to be an interventional cardiologist?
I would say that it is an incredibly rewarding field and specialty where you make a huge impact. I mean, essentially now as an interventionalist, kind of what we talked about earlier, everything that you can, what was previously done through open heart and cracking the chest, whether that's heart valve replacements, closing holes in the heart like ASDs or PFOs, stents for blockages, um, heart valve repairs, everything can be done minimally invasively now. And so it's a very exciting time to be an interventionalist, and we're just pushing the envelope. And so there's a lot of new developments. You obviously work hard, the basic advice, get good grades and do what you can to kind of get to that. But ultimately, you need to have the passion for it because it's a tough lifestyle, but ultimately it's worth it.
Yeah. All right. Well, thank you so much for your time and for being here. I really appreciate it.
Of course, man. Great to see you, Elon.
Yeah, great to see you too. I'll see you around, I guess.
All right. Take care, man. See ya.
Yeah, bye-bye. Thank you. Thank you so much for listening. I hope you enjoyed. If you don't mind, please leave a like and subscribe. And with that being said, see you in the next one.